With this said, we're kind of like coming to a nice wrap up of a proud meeting on cholangiocarcinoma. But I would like to ask again, Martin, and I will start with you because you have a lot of expertise and you helped us quite a bit in regard to the adverse events of the as we mentioned, two examples, BGJ398 and the ivosidenib. And what is your kind of like take-home message in regard to the management of the adverse events? One message for the patient and one message for the physicians.
So message for the patients is these drugs are easy to tolerate. They are actually not really difficult to manage is the message for the physicians. It really has to focus on 2 or 3 side effects that really are with lab testing and just to take the right approach, specifically around hyperphosphatemia. And obviously, don't forget about the eye toxicity. They tend to be uncommon, the eye toxicity as well. So well tolerated, easy to manage, they are here to stay.
Here we go. That's a very important message. And we have to really make sure that just knee-jerk, but rather look and reflect on what we are seeing with the patients. Andrea, another question to you. And you brought up a little bit of this in the beginning. I would love to really hash on it. Anatomical differentiation between extrahepatic cholangiocarcinoma or molecular one. Your thoughts?
Yeah, I think we're literally or already in the molecular age. We should be testing patients at even the initial diagnosis for metastatic settings and really classify them by molecular testing, not necessarily molecular classification, not necessarily anatomically. Now, anatomically do play a role in sometimes in terms of surgical options, how much they should resect, what type of surgery they should do. But by large, for oncologists, I think we should really emphasize molecular testing.
Absolutely. And this is a very important point that we you saw all of us are kind of like vouching for a new delineation of the disease. I remember historically, like almost 11 years ago, when I started getting involved in the NCI task force, first as vice chair, then as a chair, really the first question we had is, shall we split those diseases or shall we lump them together? And believe it or not, the question is not anymore valid because we definitely are splitting them, but we're splitting them not as we perceive might be, which is anatomical differentiation, but rather based on the molecular testing, as we just heard. And accordingly, you treat them as such. Very important point, just to kind of put it on the practical level. If we were, and hopefully those drugs will become available for our patients, but if a patient has a mutation, let's say IDH1, and the tumor is extrahepatic, or as we just heard from Andrew delineating those, this is to be treated still. It's not like the anatomical change is going to influence how you can treat the patient, but rather the mutation per se. Teresa, back to you in regard to the IDH1 itself. We're excited. We're kind of like waiting for the data to be presented. But nonetheless, the phase 1 itself showed that the drug has a progression-free survival, has an improvement in survival, and at the same time, it's well tolerated. But tell us a little bit more about the improvement in PFS and OS. How are you going to translate them to your patients with the ivosidenib data?
Yeah, I think that it's clear that it's a drug that we probably don't see a lot of response rate, but we stop the evolution of the tumor. And for this reason, probably the quality of life of the patients will be really improved with this drug because we can control the tumor. And of course, we have to put it together with the safety profile that it's so good. So if you put together, our patients can have the tumor control with a good quality of life. So it's...
I like very much what you said, and this is a really very important reminder for all of us that even though the response rate is always what patients aspire for, certain drugs like ivosidenib can be more oncostatic rather than oncolytic. And in other words, if the tumor is stable and in other words is influencing the patient remain on therapy and affecting as such the PFS, definitely this will be a positive kind of outcome that we'll look for. Remember one thing, however, also, we spoke about that a little bit when we were discussing the PFS, the ABC02. The PFS is really depends when you take the measurement, i.e. if you don't take a scan, you don't have a kind of point on the curve for telling you where the PFS stand. And as such, we have to really put this within the context of any study being, ivosidenib or ABC02 or what have we. Last question for you, Andrew. So we spoke quite a bit about the FGFR fusions and we proudly have done a lot of work together in regard to the BGJ398, and if anything, now it's moving into a phase 3 trial. If anything, the point that I'm kind of intrigued by is what you brought up a little bit earlier, the resistance mechanism, and at the same time, the aspiration that the phase 3 trial currently carrying on.
Yeah, so I think, clearly we need to extend the experience that we have in the right indication. So that's why, I think the ongoing phase 3 study clearly will actually test the hypothesis whether our target agents will perform as well or even better than the conventional chemotherapy. And also, we're going to balance about the safety profile, in the phase 3 trial. So this will be actually incredibly critical. We have not done that in the cholangio field yet. So that study is very important. And secondly, I do think that we have room to improve what we have already achieved with single agent FGFR inhibitor. So along that line, I still think, figuring out the resistance mechanism is absolutely critical for us to think ahead. Because these patients, they should benefit from this type of treatment, not just by 5 months, not just by 7 months, but hopefully we can provide them with additional mileage, with these therapeutic interventions.
I totally agree. And if anything, Andrew really brought up our attention and very important point. If a patient does not have a fusion protein for FGFR2 or a mutation for IDH1, and of course, or any other, it does not mean that, oops, we have no choices here. Remember, chemotherapy, and we have a lot of credit to give really for all our colleagues, especially the team from the ABC in the UK. At least we have a standard of care. It's very important to remember that chemotherapy does help patients, and we should not ignore it as being like really something from the past. We like to move things forward, as we see from what we're discussing today in regard to the molecular pathways and same time what targeted therapy we might have. But remember, even with chemotherapy is to stay. It's not necessarily yet out of the picture as it be remaining the standard of care or the sole standard of care for the disease until today. With this said, this has been really extremely informative. And if anything, I would like to thank everybody one more time for their work and their answers. We asked Dr. Gutierrez, we asked Dr. Mascaria, and we asked Dr. Zhu, and we asked everybody about where things stand in regard to the disease.